As we go through this panel discussion, I want to encourage interaction between the panel and audience, and many of you have requested that that be the case when we have these kinds of panels. We'll have plenty of opportunity for questions and for the exchange of ideas and opinions. And before I ask any of you, if you have questions or comments for our panel, I have a few myself. Charlie, I'm going to start with you, if I may. This industry is in turmoil today, and yet your system is out buying up hospitals, and in some areas which are rather distressed. And you're almost a maverick with what you're doing, but you've always had a history of great success. So when I talk about consolidation, how do you look at the whole subject of consolidation as probably one of the most, I would say, heroic, as well as one of the most gifted healthcare executives in the country?
Well, thank you, Chuck. You're too kind in your comments.
Thank you.
Some days I wonder why we are doing this, frankly. But it is an exciting time to be in healthcare, and we at Vanguard are excited about the opportunities. I've been in the investor-owned side of the hospital industry for my whole career, and what we saw is about 15% of the hospitals in the country, for all the years I've been doing this, are investor-owned. The nature of that segment of the industry has changed over time. When I first got involved, most of the investor-owned hospitals were relatively small. Many of them were suburban or rural. Many of them lacked a lot of the sophistication of teaching programs, research. In fact, in many cases, they didn't provide emergency services, limited obstetrical services. And so many of the facilities, certainly going back into the 60s, were not full-service hospitals. They were in response, in many cases, to growth and shift of population into the Sun Belt, where you saw a lot of the growth and a lot of the presence of the for-profit hospitals, the investor-owned segment. But that has changed over time, and I think more recently you've seen most of the companies who are the investor-owned companies in larger facilities, larger markets. Certainly for 2 or 3 companies like ours, there is a concentration in urban markets. This is the 5th company I've been involved with, and when we set out to do something different a few years ago, we decided that we would go primarily to the not-for-profit sector, where in urban markets there were multiple hospitals under single ownership that either were in a number 1, number 2 position in that market or had the capability of being a significant provider in that market, and bring some of the resources we had to bear. I'll have to tell you that virtually all of the not-for-profit systems that have allowed us to come in and have considered a change of form and ownership, nobody has come to us when they're on a roll and when there's plenty of money in the bank and where the operating results are terrific and where there aren't any capital needs. Those aren't the ones who call us. The ones who call are those that are in distress, and generally they're either in or close to terminal distress when they call us. And frankly, they have exhausted, in most cases, every other possibility for, more recently, accessing capital. I think over the last particularly 5 to 7 years, it's been access to capital that's been a principal driver of not-for-profit systems looking for strategic alternatives. Obviously, the lack of access to capital becomes a byproduct of a lot of decisions that have been made over the years, a failure to kind of preserve the seed corn, and operating with very small operating margins. A lot of not-for-profit systems for many years, particularly up until 2008, generated 3/4 of their income from investment income and not from operating income. So when the combination of loss of investment income hit and things tightened up on the operating side and margins were compressed, I think many systems found themselves in distress. And that, frankly, has been the opportunity we've responded to. We think that all the systems we're involved with are systems that have a reason to exist. These are not superfluous facilities. These are not redundant facilities, but they provide essential services in their communities. We do have, as a company, a disproportionate amount of Medicaid business, as an example, given the locations, because we are urban and we are in a lot of inner-city locations. We just, at the first of this year, bought the 8-hospital Detroit Medical Center system, a $2 billion system up in Detroit. And I think the poster community in America for economic distress has been Detroit, all of southeast Michigan, but frankly Detroit even more than some of the other sectors. But we believe that bringing access to capital that has a reasonable price on it through a combination of debt and equity, and we use both in our growth, making sensible capital investments, and focusing on operating results, really focusing on all the things that we over the years have learned to do well. Revenue cycle management, we're really good at that. We've gotten very good at that over the years. And we find many of the not-for-profits struggle in that area with days cash on hand. In fact, you were mentioning to me one of our Chicago hospitals that 4 days cash on hand.
Yep.
And that obviously leaves the facility very vulnerable. So I've rambled here, but
No.
we believe that there is a place for the marriage of efficient capital with some operational expertise to institutions that have a reason to be there, who are struggling, but we think can do well, can survive, and can thrive over time. Remains to be seen whether that's going to work, because, as you say, we are a bit contrarian. We're going places where the other investor-owned hospitals, not any other investor-owned company, was trying to beat the doors down to beat us into Detroit. I can assure you of that. So we'll see what happens, but we're very optimistic. We were able to take our company public a few weeks ago, so we are now a public company with broader access to equity markets. We'll see where it goes, but we're excited about what we're doing.
Thank you. Dr. Ramsey, I couldn't even get all the names out of all the groups that are coming together, Catholic Health Initiatives, yourselves, Jewish Hospital, etc. Why? Why is this happening? Would you mind telling us?
Okay, Chuck. First, I think in all fairness to the folks who are here today, I need to fully disclose. When you're the president of a university, you're not expected to know a whole lot about anything. You're expected to know a little bit about a lot of things. So I'm not a healthcare specialist. My background is in economics. And why, from the perspective of the University of Louisville, it really is a financial transaction. We at the University of Louisville have been given a state mandate to be a great school, to be one of the top universities in the country. At the same time, our state has gone through 11 budget cuts in the last 11 years. So we had to find new revenue sources to move forward. We've done what everybody's done. We've tried to manage costs. We've tried to manage our balance sheet and do those kind of things. But one of our strategies was to increase clinical income to support our teaching and research mission. And there were some things we could do with our private practice plans of our doctors. We had multiplicity of practice plans and a lot of inefficiencies there and a lot of opportunities to generate additional revenue. So we did that. But when we looked at our University of Louisville Hospital, it has been very supportive of our academic mission. But when we went through and did some strategic planning and financial analysis, particularly over the last several years with the recession and the impact of the recession, we realized we couldn't continue to operate the way we've been operating. At the height of the recession, 30% of our customers didn't have insurance. We're non-paying customers. On average, we have about 20% of our customers who don't have any means of paying for the health insurance they're getting. We're looked at as the safety net provider, not only for our community and state, and not just in emergency care and inpatient care, but outpatient and non-emergency care and so forth. So we were either going to have to really cut that back or cut back the support to the university. So we began looking at a partnership and really looking at some joint venture opportunities with one of those other providers, Jewish Hospital in Louisville, right down the street from us. They've had a great history for the academic mission, the research mission of the university. We've had great partnerships, and we actually looked at where we could help them and they could help us. They don't have a program in OBGYN. We don't have a strong rehab program. So we were looking at some joint ventures, and it was ultimately their board that said, rather than just do a series of joint ventures, let's do a full marriage, a full asset merger. So we were ready to do that. We'd done a lot of work to begin to effectuate that. And then St. Joseph Hospital and Healthcare System, which is headquartered in Lexington, but really serves many of the rural areas of eastern Kentucky, low-income areas, said, hey, we would like to be part of this discussion. So we thought a two-way merger was way too easy. We thought we should really complicate life and try to do a three-way merger between three hospital systems. St. Joe is part of the Catholic Health Initiatives, which out of Denver has 79 hospitals in 19 states. But it really comes back to a lot of the things Chuck said. We at the University of Louisville have a 320-bed hospital. We didn't have borrowing capacity to expand between the trauma center, one of the few, well, there are 2 level 1 trauma centers in Kentucky. Ours is certainly the most active. Between trauma, OBGYN, cancer, and stroke, we didn't have enough room. We didn't have enough space for our faculty physicians to practice medicine. So they're practicing at Jewish Hospital, Norton's Hospital, Baptist Hospital, VA's Hospital. And so we're losing, in a sense, some of that revenue that we could have been generating. So we needed space. We needed more beds. We didn't have any borrowing capacity. With all the changes on the horizon, electronic records management, IT changes, we really needed a partner to, one, help us get into different lines of business, get outside of just downtown Louisville and get into some of the higher growth areas and demographic areas where there's more paying customers, to be very blunt. And so it was very much a financial transaction. At the same time, the 2 partners that we've ended up with, Jewish and St. Joe, are partners that we really believe have the same values that we have, and that is better health care for Kentucky. And Kentucky is a state where we're not as healthy as we should be. We have one of the highest incidents of heart disease in the country, higher incidence of cancer than the national average, too much childhood obesity. But all of our organizations are really committed to dealing with those issues. So it is a financial transaction, but it's also a transaction about better health care for the people of our community and state.
Quite amazing for someone that really isn't steeped in healthcare. You seem to know an awful lot about it. I congratulate you. That is a great answer, and I appreciate it very much. Then we come to Mr. Don Wegmiller, who has been in the industry for approximately 300 years.
Thank you.
And
thank you. Right after the earth cooled, in there.
Don, you and I have talked about consolidation before, and you're the one that said to me, well, there are different forms of consolidation. And I wonder if you don't mind just talking about the different forms of consolidation. Am I correct? I heard you on the phone.
Did you have your hearing aids in at the time?
No, I didn't. But I wonder if you could kind of talk about.
Chuck, I think this is, and my guess is that Mike and Jim and Charlie would agree, that the changes now are significantly different in consolidation than what we've seen in the past. I don't think this is your father's Oldsmobile in terms of hospitals coming together. Hospitals have been coming together in this industry for years. Charlie is a poster child for that, has brought more hospitals into a system than probably the rest of us combined. But this is not just a hospital consolidation. And I think Jim has, in what he said were the values, touched on a number of the other consolidations that are coming together at the same time. I think the most significant consolidation has to do with physicians. Physicians are consolidating into much larger practice groups. We know that. We've seen that over the past. As a matter of fact, MGMA just said that at the present time there are only 43% of physicians that are practicing independently, obviously, meaning that almost 3 out of 5 are practicing as part of large groups or hospitals. The second is, of course, that hospitals and physicians are consolidating. And many of the bringing together of hospitals really doesn't have much to do with the hospitals, but they have to do with the physician groups that practice or are employed by those hospitals. A good example is Sanford Health, a big 30-hospital system based in South Dakota, just purchased Merit Care, 2 little hospitals in Fargo or Dismal Seepage or someplace up there. And the purpose of that is that it's the largest practicing medical group, 200 physicians in the Dakotas. Now, when you read the headlines, it's Sanford acquires 2 hospitals, missing the point. That's not the consolidation. The consolidation is Sanford just doubled the size of their practice group from 200 to 400. That's another form of consolidation that is taking place. Consolidation is also taking place between hospitals, primarily the systems, and post-acute care organizations. As soon as it became clear that payments are going to change and no longer be reimbursements, that they'll either be bundled or they'll be part of accountable care, value-based purchasing, all of the payment changes, it became very clear that acute care organizations had better have post-acute care relationships. Most of those relationships at the present time are either affiliations or contractual, but what you're already beginning to see is the major systems are beginning to buy or own post-acute care organizations. BJC in St. Louis, is SSM in St. Louis, have extensive now, in the last couple of years, extensive post-acute care networks. Why? Well, if you're going to control discharge and if you're going to prevent readmissions, 20% of all Medicare patients are readmitted to a hospital in 30 days. We're not going to get paid for that anymore. So I think that there are many more important consolidations taking place than just hospital consolidations. Is that important? Of course it is. But the hospital 10, 15 years from now, if the idea of changing the system to a value-based system, the hospital will be an important part, but it won't be the end-all and the be-all. And if you're going to deliver value, how are you going to do that without a tight relationship with physicians, post-acute care organizations, home health organizations, and the hospital? So I don't think we should miss the point that there are many forms of consolidation all taking place at the same time. So why you can't keep track of this, I don't know.
Well, Michael Means. Oh, excuse me, Charlie.
Chuck, if I could just add one comment here, and I totally agree with what Don said, and I think that's really important. Our view long term is that the hospital is going to become a cost center.
Yeah, exactly.
It's going to be a very expensive place to do those things that can be done no place else efficiently or effectively. Yeah. But if that is your source of revenue and your expected source of profit, I think you're going to be out of luck. It's going to be a very expensive cost center to a more fully integrated system that takes that risk, looks at population health, and has that full array of services. So I think Don is spot on.
So we're looking at a much different industry, aren't we?
I would hope that our revenue in our company from acute inpatient care is less than 25% in 5 years.
Is that right?
Yeah.
Boy, that's a heck of a statement. Less than 25%. Mm-hmm. Michael Means, you've been in this industry for a number of years. 1997.
Many years.
Yes. 1997, you put together the Health First entity and have done an absolutely superb job with that. You've seen a lot of different things change, but most importantly, you were one of the first to bring together some hospitals in a system, if I remember correctly. Mm-hmm. Correct me if I'm wrong.
No.
But why did you do that back in 1997? What did you see that nobody else saw?
We didn't know any better.
Oh, right.
You know, the comment that was just made about the different types of consolidation is so true in my observation. We started out with the idea that because we were hospital-centric, that was going to be the engine. In fact, we used that phrase in our strategic planning discussions, that the hospitals were the engine of the system. And my opinion is that as the, and I hate to use the word reform because I don't think it's really reform, but as the changes and the restructuring of this industry occur.
Is that what you call it, restructuring of the industry?
Yes. Yeah, absolutely.
Forget about reform.
Reform is a misnomer, at least as it's currently written.
Okay.
But our thinking really evolved way beyond that, Chuck, as we began to sit and talk about there are certain operational efficiencies that accrue from consolidating hospitals, sort of a horizontal consolidation. But in our view, the real benefits will be accrued as a result of the vertical integration and putting the physicians and the hospitals, in our opinion, the health plan, where you've got a risk vehicle, and making certain that the organization is able to take risk for the overall health of a defined population. And I think it's only through that kind of alignment that we'll ever see the real benefits. The solution that we've had for my whole career has not been the right one, and we must find a new one. And the thing that makes that so difficult today is that the incentives are simply still not aligned.
Can you give us an example?
Sure, and this is a very simplistic one, but somebody mentioned readmissions. Readmissions, we're no longer going to be reimbursed for readmissions. That's probably a good thing. Why should anybody, if your car doesn't work after you get it out of the garage, you don't pay them twice to fix it. And so that is the fact. But the physician who participates in that admission, both of those admissions, is still being paid twice. And in fact, the incentives are clearly to do more. And somehow we've got to restructure those incentives so that physicians who really drive the care, drive the cost of care, and achieve the outcomes are integrated completely in the financial model so that we all win or we all lose. And the organizations that are first mentioned in any discussion, news story, whatever, Mayo, Geisinger, we all know what they are. They've moved way beyond where we are to a model that I think is much more predictive of where we need to be.
Okay. I don't mean to be silly when I ask this question. It'll sound, but I was at a meeting recently where people started talking about ACOs again. That's still coming up. And as a matter of fact, my old publication, Modern Healthcare, has done some articles recently about systems that are good ACOs. Is there merit to the ACO concept? I mean, does it make sense?
I'm still waiting for someone to explain to me the difference between an HMO and an ACO. I mean, in my mind, it's the principle that's important. Yeah. You take a fixed premium or a PMPM payment. You take responsibility for the care of the patient, the member. You use the resources as effectively and as productively as you possibly can, and you stand on your outcomes. Is the member satisfied with the care they've received? Do they like being a member of your organization? Do they feel like it's a value to them? And ultimately, are we moving the indicators, the mass health indicators, in the right direction? Are we addressing diabetes? Are we addressing heart disease? Are we addressing stroke, incidence of stroke, and the other things that cause us to not be healthy?
Yeah, I think, Chuck, the principle, as Mike has said, and I think he's absolutely right, of being accountable financially, outcome-wise, and otherwise for the care that we render, and being paid on the basis, therefore, of the value that you bring. Hopefully, higher quality and lower cost is the beautiful equation. I think accountable care is a terrific thing. It's very positive. It's different than what HMOs were. HMOs merely shifted some of the risk through contracting and utilization control to organizations, but there was no participation and wasn't based on value. It based on payments for volumes of services. This is different. If the value equation takes hold, and I'm convinced that it will and it should, unless we think as a country that we can pay 25% or 28% of our gross domestic product for health care, when China spends 2% and India spends 1%, and we'll be competitive. We'll just give them a 20% head start. Unless you believe that, we have to pay differently. And I think this is as good a way of making that change as there is. It now brings together the payment enterprise as well as the other enterprises that deliver the care. I think the ACO part of it, you're not going to see much interest in that on the CMSs. I mean, they blew that pretty badly. But I think where you are seeing activity in actually forming these organizations is between places like Advocate and Blue Cross Blue
In
Shield
Chicago,
of Illinois.
Advocate in Chicago? Yeah.
And there are 18 or 20 of those announced already between providers of care, physicians, nurses, hospitals, and insurers coming together to say, listen, let's work together, increase the value quotient. We're not going to reimburse you anymore for costs. We'll pay you for your results. We'll pay you more, we'll pay you less, depends on your results, but we'll work together to do population management, so on. That principle, as Mike said, that's a great principle, I think.
Go ahead, Mike.
Just one other quick comment, going back to what Charlie said about hospitals being cost-centered. You know, that is so hard for organizations like ours to accept. Most community-based organizations, and starting with the board of directors, if you sit down with them and you say to them, well, you know, this hospital that you've worked so hard to build over all these years is now a cost center, and we're trying to drive down the reimbursement as a percentage of our total revenues, we end up fighting ourselves because there's not solid buy-in to this industry-wide change of philosophy. And until we get there, we're literally fighting each other in the attempt to try to build a better mousetrap. And that's unfortunate. That's not as much true in the for-profit industry, in my opinion, because they do have alignment of their strategies and their financial strategies and their strategic development.
One of the things that is interesting me, you know, you're talking about consolidation, physicians coming together, running back I'm sorry, I shouldn't use that word, are not coming back to hospitals as employees. And that changes the practice of medicine in many cases. I don't know whether that's a good thing or a bad thing, because the last time that happened, it didn't seem to work very well because hospitals weren't prepared to work with physicians and physician groups. So, I mean, any observations on that particular part of it?
Let me just say that going back to the stellar examples that get mentioned in every news story, every newspaper article, and ask yourself how those physicians are integrated into the organization. In almost every case, they're salaried employees of the organization. And there has been a lot of effort spent over the years by the medical industry, in my opinion, to try to refute that as a model that can work. But in fact, it does work, and it works better than the model that I've operated under for all these years, where physicians are independent of the institution and they're billing based on fee-for-service. And so my opinion is absolutely, and not only can it work, it must work.
Okay. Charlie?
Charlie?
Yeah, I think just straight employment of physicians is not a preferred mode for me. I don't like as much working with physicians as our employees as people who had shared economic interest. I think it's very important that we share in the responsibility, the accountability for the outcomes, the quality of care, the coordination of care, the patient satisfaction. Don Berwick's triple aim. I think we need to be joined in our effort to get that. Employment is one way to do that, and there are some cases where I think employment may be the most appropriate relationship between a hospital and doctors. But I, for one, don't want to employ all of our doctors, and the reason, I watched a lot of my colleagues in Nashville who got into the PPM business a few years ago and then all got out of the business when they found something that kept me out of it to begin with. Is I've never found a group of doctors who want to work harder for me than they'll work for themselves. And if I could find a group that would work longer hours, needed less overhead, less support in the office, didn't need more help, newer equipment, fancier digs, bigger offices, and shorter hours and more vacation, I'd love to employ doctors.
Are you employing doctors now?
In some cases. I think there are some cases, and there are certain specialties where, because of the relationship between their work and the location of that work in the hospital For example, cardiology is one specialty that now has virtually en masse wanted to move into employment status, and that's all around how they're paid, because all of a sudden their incomes were threatened. So now there's not a cardiologist in America who's not throwing themselves at a hospital saying, buy me, buy me. I mean, it just is happening, and we have bought some of those because we don't want to be without cardiology.
Of course. Let me ask you a question, Dr. Ramsey. As you bring these entities together, Catholic Health Initiatives and so on, is the whole physician part of it gotten some attention, or
A little bit.
are you getting any pushback? I imagine quite a bit.
You know, if you look at physicians and the challenges that they present, and then make them faculty members, that sort of compounds the challenges. But then in working with Jewish and working with St. Joe's, they have combination of employed physicians and community physicians at both those institutions. So one of our biggest challenges, and as you enter into a consolidation, certainly one of the things that you've got to be very sensitive and work through are all the employee issues, but you know, Don's absolutely right. The physician issue is a huge issue, and will undermine the success of our initiative if we don't do it right.
Okay, Charlie?
Chuck, another point there is I think the management of professional practices is a very different skill set. And I, for one, having been in the hospital side of this for a long time, think that we in the hospital business are really pretty lousy at a lot of these other related things we need to start doing and learn how to do. Hospitals typically don't do a great job managing some of these lower cost outpatient or inpatient settings. They historically have not done a great job with skilled nursing or with rehab or with psych or with other programs, because the mentality, if you start with the acute care hospital, is what can we chip away to get down to being reimbursed a third of what we would be paid as a hospital. And you can't start with what do we chip away with what we have. You have to start with what do we have to build up from the bottom. And so I think in the case of our company, we don't do nearly as effective a job as we should in how we manage the practices we have and how we manage our relationships with the physicians.
And Chuck, that was certainly our experience. Mike has referred to it, and that's why so many hospitals are still, and appropriately still, gun shy about employing physicians. When we started in Minneapolis, started employing primary care physicians back in the 80s, and now Allina has something like 700 employed physicians. Charlie's absolutely right. We didn't know anything about running a medical practice, had hospital people helping them, and that's all changed. I mean, the Allina Medical Group now is run by very sophisticated medical professional management people. Physician leadership of the medical group runs the medical group. The hospital people are told to keep their damn hands out of there, and because you don't know anything about it, and that's absolutely right. So I agree with Charlie. There is some learning taking place by these systems. Mike's experience in the physician group it was one of the early ones as well, and my guess is it's done differently today than it was in '97.
Well, I agree with both of you. We historically have not been very good at that.
Right.
But I guess what I would say to everybody out here, I'm retiring, so it's going to be in your lap. You better get good at it. You better get good at it. In 1996, when we started our health plan, which is an HMO, it's an internal program, and we didn't know jack about it. You know, just candidly, we didn't. But we went out and hired people that did, because we believed that was going to be an important component. And I would just say that, again, and I'm not trying to pick a fight with the AMA here, but you know, the medical industry has done an excellent job of convincing all of us that doctors can't work for us, that they can't be part of a team. Well, you know, we have Harris Corporation, as their world headquarters is in our hometown, and it's a Fortune 200 company. They're on the Dow now. And they have a host, Jim does, a host of brilliant scientists with degrees and education way beyond a medical degree. And there aren't any of them who are billing fee for service. I'm sorry. Now, if you ask them, would you like to, professor, be able to bill the government for every student that you see, or for every class that you teach, or for every research paper you publish, and do that independent of the university, would you like that? I mean, they'd all be raising their hands and saying, sign me up. But that's not an option. I'm, again, not trying to be too contrary, but we have been lulled into this state where we've pretty much abdicated the management and the integration of one of the most important component in an IDN. It is without a doubt the physician population. And I say they've got to be integrated, they've got to be hitched to the team, and their compensation can certainly include rewards, it can include stock options. I mean, there are a lot of creative ways to make them want to work hard for you.
Let's don't go too far.
But that's something that I feel very passionately about. We better get good at it. I agree we're not good at it now, but we better get better.
That's interesting to hear. And more physicians, by the way, are getting advanced degrees, aren't they? MBAs, and I've even run into a couple of physicians, not only got their MBA, but their law degree, which is dangerous as the heck, I know. What I'd like to do now, because we're getting along here, there must be somebody in this audience that has a question, and I thought maybe I'd get more participation. Yes, sir. Now, can we get a microphone on this gentleman, please? And would you identify who you are and where you're from and the question? Thank you.
My name is Steve Huckabee. I'm with the Kettering Health Network out of Dayton, Ohio. My question is, you've mentioned the word consolidation quite a bit, but I also heard a little bit about the medical home concept and where that's going, not under the guise of ACO, but there are a lot of alternate care sites in your communities that are owned by corporations. So how do you see receiving that bundle of money and being able to manage that across that continuum without ownership of that continuum? Retirement homes, nursing homes, and the like.
Just the whole panel, or do you
anyone in particular?
Okay.
Somebody that's getting ready to retire, like Frank Perez that retired last year.
Charlie?
Well, I'm only 69 and have a 4-year-old daughter, so I'm not going to retire.
Oh, good man.
We were espousing a view, and the last company I worked for, we had about a million fully capped lives. That was back in the 90s. And half those were in Southern California, and we had some in some other places. And we did very well with physician partners. In our case, we were working in California with large medical groups. So we had the hospital system, there were medical groups, and together we went for 100% of the premium to the payers, and then we bought the services. In the case of hospitals and doctors, we provided much of it, but we just purchased what we needed to supplement what we had to offer the comprehensive product. And I developed a view at that time that, to me, an integrated delivery system covers a geography. You sort of draw your circle and cover your geography. And within that geography, you need to have participating all the elements of a comprehensive delivery system. That's hospital, doctors, pharmacy, nursing home, home health, everything you can name, and all those specialty services you mentioned need to be available in a bundle. And the trick is, how do you bundle across that geography and the population within that geography and that variety of providers? How do you bundle a payment that makes everybody in the system economically indifferent as to where the service is rendered? Because what fee-for-service drives is I have to sell more hospital service because I get paid for units of hospital service. And so if that's all I have, and that's my revenue and that's my expense, then I want to sell as much volume of that as I can. But now all of a sudden, if I have total responsibility for a premium for all the care, including hospital care, now I want no hospital days. So I go from wanting all the days that we can get anybody to pay for and somebody to lie still in bed and accept, to I don't want anybody there. And that is the big difference, and that is the trick. How do you move from one way of thinking to the other? But I think it's that ability to share risk, and I don't think that one entity has to own all of those elements. I just don't think that's practical, that one organization owns every single piece of an integrated delivery system. But I do think what's going to be needed in the new payment reform is more flexibility for the movement of money through the system so that people are in the appropriate setting at the right time, so there is one clinical and medical record that everybody shares, so we're not doing the duplicate testing, et cetera. I mean, if you think about it, every provider in a fee-for-service world has the incentive to redo everything that got done at the last stop. We all have the incentive to do all the labs again, do all of everything else again in a fee-for-service world. One of the things I fear is that we're going to be so stymied by regulation that the markets won't be able to operate. For example, we were selected as one of 5. We had 2 of 5 demonstration projects around ACE, the bundle payment. We had cardiology and orthopedics in our hospital system down in San Antonio. We've had that for 3 years. We've done very well. It's going to be extended. The cost came down. We got orthopedic surgeons who had fought with each other for years over which implant do we use. I had 6 different implants. The cost was from $2,100 to $3,800 for a particular implant. Once we had the ability to share savings in one night, we got down to we're going to pay $2,100 for implants. We'll say to all 6 suppliers, if you want to furnish us implants at that price, we'd love to have you. 2 fell out and didn't. They said, we're not going to do that. And so we said, you're no longer a supplier to us. This is what we pay. All the surgeons supported that, and so we were able to make it stick. I mean, you guys do this all day, every day, but one of the reasons it's so tough to get control over some of our cost is this discretion that physicians have and the relationship they have with vendors, and then the hospital just becomes the parasitic host to people who insist that we have to have all this selection, we have to have all this stuff. The more encouraging thing to me was not just that we immediately had big supply savings, particularly around the implants, but other supplies, but they quickly got about work that they had never agreed to do together. They sat down as a group and said, let's develop protocols around how we're going to do a knee. And let's have one way we do a knee, not that just that we use the same implant, but let's sit down and compare, what do I expect now on admission? What do I do day after surgery? You know, when do we discharge? When do we ambulate, et cetera? There's got to be a best way to do that. The evidence is there. And so they sat down over a period of several months and developed clinical protocols that have resulted in even greater savings. So the supply savings sort of paled once we got the staff efficiency, the efficiency in the operating room, because we're now doing the same procedure the same way every time. We don't have to have 5 different reps running in and out and to tell us which screws to use. It works. But remember, we would be in jail for doing what we did if we didn't have the ACE demonstration projects, because we can't share those savings with doctors. And the results are better. The patients are happy, results, the outcomes are better, cost is down, we get a third, the doc gets a third, and the patient gets a third cash refund. Pretty good deal.
You're darn right it is. Everybody wins. Any other questions we have? Yes, sir. You and this gentleman in the back here, please identify who you are, sir.
Dave Harlow with Carillion Clinic out in Virginia. To kind of capitalize on what Chuck mentioned earlier about human capital, you know, if we believe the statistics that the physician population is, number one, declining and aging, and if we look out to 2020 and we see essentially 90,000 less physicians than we really need, and the perfect storm of healthcare changes, one of the things that we look at, or at least I'm looking at as a mid-level director at Carillion is, you know, how do I mesh what I'm doing with what the organization is doing? So one of the things, of course, are chronic diseases. And chronic diseases, just by definition, are the big cost drivers in healthcare. So one of the ways that we are contemplating, at least looking at working on that, is creating different relationships with the human capital of the pharmacist in the healthcare system to be more of a direct patient partner with physicians and reallocating that manpower across the system. My question to you is, how does that feel to you, number one? And number two, in terms of chronic diseases in your organization, based upon just the sheer dollar volume, what kind of techniques are you using to attack that? Because it seems to me that if we don't correct that problem, then all the restructuring in the world is not going to solve our financial problem.
Michael, can you want to take that on?
Sure. How many people here have been in the military? A few. Military, in my opinion, has done a wonderful job in terms of deploying their resources and their assets in their healthcare delivery network. In the military, you take a corpsman, you put them through basic training in AIT, and that individual is trained to start IVs, do IV meds all day long, et cetera, et cetera. We're going to have to break down the fiefdoms that have been created through regulation, through professional associations, that basically say that unless you're a carpenter, you can't touch a hammer. We're going to have to get much, much better at using ancillary people, and quality will not suffer, I promise you. You know, there is so much that the certifications and the licensure restrictions, et cetera, are driven by economics. They're not driven about what's best for the patient, and certainly not what's best for how much we're spending on healthcare in this country. So we're just going to have to do more with less. We're going to have to train more physicians. I mean, goodness gracious, we've got hundreds of thousands of kids, young people who are very, very well qualified, every bit as intelligent as they should be to take on a medical education. And if we really want to do something about this issue, rather than opening the floodgates and bringing in folks from everywhere else in the world, let's train our kids. Let's send them to medical school. Let's give them incentives to be doctors. And that's a solution. I had lunch several years ago with Newt Gingrich, and he asked me the question. He said, "What would you do if you could do one thing?" I said it would be to quadruple or by tenfold increase the number of new medical students that are enrolled in our medical schools across this country. And it could be done. The cost of capital wouldn't be that high, and it would make such a difference in the environment.
I agree with Mike that, and we've been the hospital industry at least has been in Capitol Hill for a decade saying, you understand that we have fewer physicians per population now than America's ever had. It's declined by 26% over the last 10 years per population. So we need more doctors. And they said, yeah, well, we'll get to that. We don't have time for that now. So in the interim, until that happens, I think we're going to see an expansion of the medical home concept in these practicing medical groups. My former system, Allina, has gotten all the primary care physicians together and looked at how big a panel of patients can a primary care physician handle under the current model, doctor-nurse. Doctor sees everybody, passes a few off to the nurse to follow up, but he sees everybody. And they said, if we stretch it, we can probably do primary care physicians, 2,000 patients. If that model were changed so that the captain of the ship was the physician, the primary care physician, but he had a physician assistant, he had a nurse practitioner, he had a care coordinator, he had the typical physician nurse, how big a panel? They went through and said, well, we could probably handle 5,000 patients on our panel. There's a small little increase there of 150%. So I think that there are these mechanisms available. I agree with Mike. Until we get more physicians, we have to employ that. Geisinger has had a great experience with physicians that are not a part of the Geisinger health plan or part of the Geisinger. They went out into the rural communities of Pennsylvania because they were seeing all of these admissions coming in to Danville and other hospitals that didn't really need to be hospitalized, but there wasn't enough manpower out there to deal with them. So they said, listen, to the primary care physicians, we'll put nurses and physician assistants in your practice at our expense because there's no need for these patients to be hospitalized, which, since we run the health plan, comes out of our pocket. So we'll invest in your practice. So they did. Admissions dropped 22% basically from day one. Patient satisfaction went up enormously. The docs in the rural practice said, thank God, where have you been all of my life? I actually have a life again. So can we change the deployment of human capital? Hell yes. Why not? I think we need to. I don't think we have any choice. The Congress certainly isn't going to listen to us anymore about more physicians than they have for the past 10 years. So I don't think we have any choice. But I think these are actually very good choices, as Mike Bean said. This is actually improved quality and patient satisfaction.
Don.
Let's just get on with it.
Don, one of the problems I have, I've been to Washington quite a bit.
Where are you? You
Right
walk
over here.
around? Do we all get up and walk around? Yes. Oh,
Please,
sorry.
yes. Now I've forgotten what I was going to ask you.
Washington.
You've been to Washington quite a bit.
Yeah.
You've been to Washington quite a bit.
Thank you.
Yes, you were
Thank you,
complaining
Charlie.
about Washington.
My God. And I've talked to a number of our legislators, and I don't find anyone in the Congress, basically, that really understands this great industry that we're spending so much money on. What? They're now claiming 18-19% of the GNP. I've met with Zeke Emanuel, was one of the architects of healthcare reform. But the point of the matter is, all of these things that we're talking about are great, but who's going to bring this about? That's what I worry about. I mean, we have all kinds of institutions going to stand in the way of more physicians, you know that. Not only the AMA, the AAMC, I'm sure, and others. But there seems to be so many impediments to real change in healthcare. This travesty that came forward, healthcare reform bill, is filled with unintended consequences and all kinds of other things, and it's unfortunate. But when are we going to be able to really free up the industry so that market forces really do the things that need to be done? We know there's been reform for many years going on in healthcare, but now I think we're at a time where revenue's drying up. Things have to really change because we're at a critical period in our history with healthcare. But where is this going to happen? Who's going to make it happen? It has to come from government, I would think, or am I wrong?
My take on it is what Charlie said. If they don't burden the industry with regulation, which is, I think, a real concern, there's plenty of innovative leadership. Geisinger didn't go to Washington and ask for that program.
I know.
He said, well, we know how to solve this program. We're smart people. There's plenty of smart people in this industry. Is this industry filled with as much innovation as any industry? We're throttled with regulations. Physicians and hospitals can't do this, that, and the other thing in some instances unless they're employees. Well, why should that make a difference? So if they just stay out of the regulatory business or get out of what they're in now, I think we've got plenty of leadership.
Yeah,
Charlie,
Chuck,
Jim?
I'd agree with everything that's been said about the regulation. I think that is a big concern, not just in our industry, but across all industry right now. If you look at many of our businesses, if you look at why aren't they creating jobs, they've got a lot of cash. They're just concerned about, one, uncertainty in the regulatory environment they're going to face and so forth. So I am very concerned about that. I think at a micro level, what we hope to do is we hope to be the group in the Commonwealth of Kentucky that takes on these issues
And makes it happen.
through a statewide network and
Yep.
through, in our strategic plan, understanding the concept of the vertical integration that was talked about earlier, from really being involved in all aspects, cradle to grave. So I think that there's no question the policy environment is uncertain. The policy environment is very important. But I think that in some communities, in some markets, a lot can be done by just the organizations themselves. And in our case, we see that as our mandate as an institution of higher education in Kentucky.
Excellent. Yes, Charlie.
Chuck, I agree. I don't think we need to wait for leadership from Washington. I think we know enough about what is going to work in the future that we can begin moving in that direction. There are some impediments. Fee-for-service is an impediment. If you think about the whole regulatory side and the fact that I read this morning, we're going to beef up some more fraud and abuse, right? Because there's too much money being lost to fraud and abuse. All the regulations, or many of the regulations, are designed because we have a fee-for-service system. I'm going to pay you per, so I have to be sure you don't do too many pers. And you don't do one of those pers in another institution that you happen to have a financial interest in, and you don't do one that's medically unnecessary, so I got to regulate the dickens out of you. If you change the payment system so you pay for outcome and result, and then let the market underneath that allocate the resources where they need to be, you can dismantle all the fraud and abuse. It goes away. There's nobody to defraud. The fraud comes because on a fee-for-service world, set yourself up a clinic somewhere, turn it into a mill, run a bunch of Medicaid patients through there, get reimbursed, and then Washington goes gaga over we've got fraud. We've got fraud because that's what the system spawns.
Yep. Yep.
It begs for it.
Amen.
Okay, I agree.
Chuck?
And by the way, I don't
This
think the
lady has a
healthcare
question.
system is broken, Chuck. I think the healthcare system is working exactly the way it's designed to work. Everybody's doing what they're incented to do right now. You've got to change the design if you want to change the result.
Thank you. Ma'am, may we? One last question.
We're at the
No,
end.
my God, wait a minute. There's a lot of
It
people
just
that have
seems
questions.
like we've been here for
No,
years.
it seems.
A question. I agree with the comments that have been made. It's clear that we have to change the fee-for-service system. It's clear we have to align physicians and so forth. There's another big driver that it seems to me that neither physicians nor hospitals have adequately figured out how to deal with. And the driver is the public. It's our love affair with new medical technology, with innovation. It's the direct-to-consumer advertising. It's the demands that consumers place on the healthcare system for the latest and the greatest, even in the absence of evidence that shows that these things make a measurable difference. All you have to do is look at the rapid dissemination of the Da Vinci robotic, and you have a classic example. And there are many, many other examples like that. So even with the alignment of physicians and even with the movement towards a population-based, value-based reimbursement system, how do we deal with direct-to-consumer advertising, and how do we deal with the public and our own infatuation with new medical technology in the absence of evidence showing effectiveness and safety?
That's a tough one. Now
Let
you're
me
talking.
take a crack at that on a personal basis. I've had the same internist for 15 years, and I would go to him and do what consumers did when it didn't come out of my pocket because somebody else was paying for it. That's one change that has to be made. However great this is, if I have to pay for that MRI, hey, but I would go to him and he'd say, sure, right, yeah, that's right, we'll set you up. We're doing an MRI, maybe we'll do some brain surgery on you too, what the hell. So I went to him the other day. He's now employed by Allina Health System. And so I had a conversation about something, and he said, you don't need that. What do you mean I don't need it? But I just read it's the best. And so he went through the research and so on, spent about 10 minutes basically saying, you're not going to get that. Difference? It's not paid on fee-for-service anymore. Two big changes. Let's have consumers start paying for some of this. Let's have doctors not be paid on fee-for-service. Sure saw a behavior change in one doctor. Maybe that won't change anybody else, but I think I'd be confident to make those two changes. I wouldn't worry about drug advertising much after that. As long as you tell me that it's got to come out of my pocket. Oh, thank you. No, I don't think so.
Charlie?
Chuck, we have a number of fairly big initiatives for us going within our company, because the other thing that very much picks up on your point, and I think it also takes off on the point that was made earlier about chronic diseases, the cost of chronic disease, is the thing that I think we need to all be cognizant of is that people are in the healthcare system. They're in the hospital or seeing their doctor less than 1% of the time. 99% of the time, people are out there living their lives, in many cases in ways that are tremendously costly to the society. And the choices people make with their lifestyle, if you look at the cause of so many of the diseases, I mean, look at all the things, and I'm not a good one to be talking here, but the lack of exercise, the lack of proper diet, the environment that people live in. We've initiated something, and we're starting in a couple of the communities at community level, individual level, with So Healthy, a garden for the community. This sounds a little bit hokey for a hospital company, but we believe unless we can start not just educating, but creating a network, an influence, some kind of affinity
Yep.
amongst people to be more concerned about their own health. We're trying to do this for our own employee groups. Hospital employees are the unhealthiest population out there. There's no other industry that's as unhealthy as hospital employees. And so if we can attack there and begin to get people to take more responsibility for their health, some of it is financial, but financial alone, nobody's ever been able to get there with just we're going to pay you to run or lose weight or stop smoking. You've got to build somehow communities that give people the support they need to make those decisions and stick with them. I mean, fat people have fat friends, you know, that's kind of how it works. So you need to get, somehow, we need to use our influence, not in a big brother way, but to be sure not just the education is there, because most people know what to do. Look, those of us in this room who are heavier than we should be, we know that's a problem, right? If we're not exercising, we know that's an issue. So what can we do to influence populations to think and act in healthier ways? And I think that is where healthcare costs could be cut in half. I mean, half of it could go away.
Yeah, I totally agree. I think the other thing is from the Academy's perspective in terms of research and what we're doing in healthcare research, you know, let's not overlook the huge breakthrough we had with the Human Genome Project and what that means in terms of changing the whole practice of medicine away from, we're not there yet, we've got a long way to go, but away from diagnosis and treatment to prediction and prevention. And I think that as a result of the Human Genome Project and the genetic structuring, we can get into more personalized medicine. So it's a long way down the road, but that's a real hope for us from a research perspective.
Mike, you wanted to add
Yeah, very quickly, a couple of comments. One is I hope that this country never loses its fascination with technology, whether it's hard technology or pharmaceutical technology or whatever. That is, I think, one of the brightest spots in American healthcare. Now, that being said, what we've got to do is just tell them no, okay? We've got to create incentives in the accountable care organizations or HMOs or whatever the final acronym happens to be, where we use evidence-based medicine. We only approve and authorize those procedures that have merit, that get results. And that it will take a lot of the discretion, I think, away from people being able to say, I just got a new MRI, so I think you need one, to saying, for your particular case, with this particular presentation, you know, an MRI is just not indicated, and we're not going to pay for it. And I hope forever you'll have the opportunity to go down the street, if you so believe that that's what you need, and buy it.
Out of your pocket.
Yeah, out of your pocket. But we've got to have the discipline, and the new electronic medical record will help us with evidence-based protocols that will clearly paint the picture for the right therapeutic model for a given set of conditions. And
one more question. Is there anybody here that has a question?
Chuck, over here.
Thank you. Doctor, for goodness sake, stand up, our hero.
Listened with quite a bit of interest as you guys have kind of talked about integration and hospitals and physicians working together. And I certainly can't disagree. Mercy and integration, integrated physicians kind of go hand in hand. But one thing that I haven't heard mentioned much, I've heard that like physicians to take more financial responsibility and more risks along with the hospital. But a lot of our medicine is defensive medicine, and a lot of the tests and studies that we order are consumer driven. They know that they're out there, and if we don't order them, it's our license and our malpractice, et cetera, that's at risk. And what I'd kind of like to hear is, I know we're not going to solve tort reform here, but I think before total integration is going to occur, there's going to have to be some kind of banding together as far as physician protection if we're working for the hospitals, and trying to keep or testing and resources to a minimum. I was just wondering if somebody could maybe comment if there's something out there that might be on the horizon as far as doing that.
Who would like to address that question?
Well, the defensive medicine is, as I think all the studies have shown, and certainly your comments indicate that clearly that is a cost factor, and for very real and practical reasons for physicians. And you mentioned them. Malpractice, professional reputation, and so on. Clearly, on a state level, when the politics are amenable to understanding that if you're going to continue to put all this burden and unlimited liability on physicians, you're going to get defensive medicine. When that has been addressed, there have been some significant changes in what malpractice rates have been. So the problem is when the politics change, those safeguards are thrown out, and on the national level, there's never been any interest. I'm always interested when whatever president it is at the time says that he's going to address defensive medicine and we're going to deal with the trial lawyers and so on, and of course nothing has ever happened. So I think that's one element that is constantly beyond the reach of control of the industry and lies, I think, in the hands of our political leaders, and generally speaking, they drop the ball. So I don't know how to fix that.
I have a daughter who just graduated from law school and a son who's in his second year of law school, and I feel very differently about this than I used to. I really think, Gary, that the key is sort of tied into the comment earlier about evidence-based medicine. We need to offer protection to practitioners of any specialty who follow evidence-based guidelines. And it's not that hard to do. Our data systems are now going to make it easier and easier. Those evidence-based protocols are become more and more well-defined, the cookbook, if you will. And the cookbook's not a bad thing. No. It doesn't mean that there won't occasionally be deviation, and it doesn't mean that sometimes we won't make mistakes. But there need to be protections built in for people who follow the most evidence-based practice and protocols that are available in the literature. I think it's a fairly simple fix, but the problem is that people who vote on these laws are all lawyers themselves, and they're not anxious to change it. It's like doctors not wanting to change fee-for-service. So why would you?
We've come virtually to the end of our discussion, and I really appreciate you being here, and I thought it was generally a good discussion. I always like to ask a question at the end. Are you optimistic, Charlie, about healthcare in the future?
Absolutely. I think that in any industry, and that's certainly what we're in, the more uncertain the times are, the more troubling they appear, the more opportunity there is to make things different and to make them better. And so I'm very, very optimistic, only because it looks so bleak.
Good.
It's got to get better than this.
Mike, you're retiring. You're going into a new chapter in your life.
But now I'm going to be a Medicare patient, and I've got a lot invested in this. I'm optimistic as long as we have the national will to change the system. My biggest fear is that we will not muster that will, or that politics will prevent us from restructuring the industry. And to stay in the status quo, I think, just only has a very ugly outcome. So I know that the answers are there. You folks know that the answers are there. And what we have to do is find the Constitution among us to make the changes that are necessary. They're going to be big changes, not going to be pleasant. There'll be a lot of rice bowls tipped over.
Dr. Ramsey, as an educator, an academician, basically?
I'm very excited. I think there are a lot of challenges, and I think we've got to be part of the solution and work, admit it's going to be different, it's going to be challenging, but try to be part of the solution. But when you look at medical research and the advances that are being made today, day in and day out, at our university, in spinal cord work, in adult stem cells, regeneration of the heart, some of the work that we're doing, I'm very excited.
Good. Don?
I agree. I think we're at a point where we can make the change away from the old system to a value-based system. And I think any industry that can be based on the value that it delivers to its consumers is in a much healthier position than one that gets paid regardless of the outcome. And I think that we're at that point. I think the deliverers of care, physicians, nurses, healthcare administrators, and others are frankly eager to make the change. And I agree with Charlie and Mike and Jim that if the regulation doesn't throttle this, I think we're on the path to a very exciting future. A lot of bowls will be tipped over. I understand that. But that's true of any change. Even if it were a negative change, we'd be tipping over bowls. So I think it's going to be very positive if they stay out of our way.
Just take a moment to say thank you, Dr. Ramsey, for joining us today. Enjoyed your comments. Don Wegmiller, thanks, Don, for being here. Michael, good luck with your so-called retirement, which
Always
isn't
a
going to
pleasure.
happen.
Thank you.
And Charlie Martin, you're a contrarian.
Keep slugging.
Exactly. Thank
Life
you.
is just what we do while we're waiting to die.
Thank you very much, ladies and gentlemen.